Welcome to the Explainer. Today, we're going to put on our detective hats and tackle one of the most fascinating and honestly most commonly misunderstood mysteries in all of clinical medicine. We are diving deep into sodium disorders. We'll look at what happens when it's too high, when it's too low, and everything in between. But to really do this right, we have to completely reframe how we look at sodium in the first place.
Here's our quick agenda for today. 1. The sodium-water balance. 2. Hyponatremia, too much water. 3. Hypernatremia, the water deficit. 4. Neurological dangers. And finally, 5. Restoring the balance safely. Let's jump right in.
Section 1. The sodium-water balance. Rethinking salt as a water problem.
Okay, so to truly grasp what we're about to cover, we first need a massive paradigm shift. Think about this for a second. What if a sodium imbalance has almost nothing to do with actual salt? This right here is the core mystery we've got to solve out of the gate. In clinical medicine, when you see abnormal sodium levels on a patient's chart, you're actually looking at a reflection of abnormal water levels. It's really a volume problem that's just masquerading as a salt problem. The answer to this whole mystery comes down to ADH, or vasopressin. You can think of this hormone as the absolute master key to unlocking why our blood becomes too concentrated or too dilute. So, ADH acts on these little V2 receptors in the kidneys, and it tells them to pull water back into the bloodstream. If your ADH is high, your body is hoarding water, which dilutes the sodium in your blood. But if ADH is suppressed, you just pee out that water, which concentrates your sodium.
Moving on to Section 2, hyponatremia, too much water, the dilutional effect.
All right, let's start our real detective work on the lower end of the sodium spectrum, where water is basically overwhelming the body's system. The magic threshold you want to remember here is 135. Anything below 135 milliequivalents per liter signals hyponatremia. But here's the trick, guys. Our very first diagnostic clue isn't actually staring at the sodium number itself. The absolute first thing we do is check the urine osmolality to see if ADH is turned on or off. We have to know exactly what those kidneys are doing with water.
Now, here's a really great clinical hack. We can perfectly categorize our patients and narrow down the culprit just by doing a basic physical exam. Using the rule of threes, we ask, are they hypovolemic, meaning are they totally dry with poor skin turgor? Are they euvolemic, where they appear completely normal but just have a tiny, microscopic water excess? Or are they hypervolemic, presenting with massive fluid overload, crackles in their lungs, and pitting edema?
And this brings us to our first major diagnostic fork in the road. On one side, a high urine osmolality, anything over 300, tells us ADH is actively turned on. The brain is either appropriately or inappropriately hoarding water. But on the other side, a low urine osmolality tells us ADH is turned off. The kidneys are desperately trying to excrete water because the patient is simply drinking way too much, like what we see in primary polydipsia or beer potomania. So let's say your patient is hypovolemic, right? They're totally dry. By cross-referencing that dry volume status with their urine sodium, we can instantly tell if the kidneys are leaking the fluid or if it's escaping from somewhere else. A high urine sodium means the kidneys are dropping the ball. This is usually due to diuretics or low aldosterone. A low urine sodium? Well, that tells us the kidneys are actually working perfectly to conserve sodium, meaning the fluid is escaping from extrarenal routes. Think the gut through vomiting or the skin from severe sweating.
But wait, what if their volume looks completely normal, yet their ADH is just sky high? Well, then we have to hunt for SIADH, the syndrome of inappropriate ADH secretion. And honestly, look at these triggers. You've got CNS injuries like strokes, pulmonary diseases like pneumonia, common drugs like SSRIs, or, and this is wild, even malignancies like small cell lung cancer that autonomously produce their own ADH. Just keep in mind you absolutely must rule out thyroid or adrenal issues before making an official SIADH diagnosis.
Section 3. Hypernatremia, the water deficit. When the well runs dry. Let's flip to the totally opposite extreme. Crossing above that 145 mark builds a picture of severe dehydration and a hypernatremic water deficit. This is heavily driven by either an inability to drink water or a massive loss of it without any replacement. Normally, an intact thirst mechanism protects us from this. So when we actually see it, we're usually looking at intubated patients, the elderly, or folks with altered mental status who literally just cannot access water.
Here, we're comparing two really notorious euvolemic culprits. Both of these cause massive dilute water loss in the urine because the ADH system is basically failing. In central diabetes insipidus, the pituitary gland completely stops producing ADH, which is often due to brain trauma. In nephrogenic diabetes insipidus, the kidney V2 receptors are broken and just fail to respond to ADH, often linked to lithium use. The clever trick to tell them apart: if you give synthetic ADH, desmopressin, it will only fix the urine concentration in the central type. Okay, we can organize all this chaos into the ultimate cheat sheet for high sodium. Hypovolemic means pure water loss from things like osmotic diuretics or severe GI issues. Euvolemic points straight to diabetes insipidus. But check out the hypervolemic category. This shows how things like an aldosterone-secreting tumor or even iatrogenic causes, like a hospital literally pumping a patient full of hypertonic IV fluids, can dangerously overload the system with salt.
Section 4. Neurological dangers and complications. The high stakes of water shifting. We really have to care deeply about these numbers because the true consequences are happening inside the rigid, unforgiving vault of the skull. The absolute rule of thumb here is that water strictly follows sodium. The stakes are literally life or death because sudden osmotic shifts physically alter the shape and function of our brain cells. If the blood gets too dilute, water rushes right into the brain. If the blood gets too concentrated, water gets sucked right out of the brain tissue.
Because of this, we walk a terrifying clinical tightrope. A sudden drop to a sodium level of 120 can cause acute cerebral edema, leading to massive headaches, seizures, and potentially fatal brain herniation. But, and this is a huge but, if you try to fix that low sodium too fast, it causes osmotic demyelination syndrome. If you push salt in too quickly, it aggressively sucks water out of the brain, destroying the pons and leaving the patient locked in and permanently paralyzed. No pressure, right?
And because of that terrifying risk, 6 to 8 is your magic clinical threshold. You must never correct sodium by more than 6 to 8 milliequivalents in a 24-hour period. You have to monitor this obsessively. If you overshoot that number, you literally have to actively bring the sodium back down with water just to protect the brain.
Section 5. Restoring the balance safely. Step-by-step treatment protocols. Now that we really understand what's at stake, let's map out exactly how to rescue these patients using some logical step-by-step treatment protocols. Here's the sequence for hyponatremia. Step 1. If they have severe acute symptoms like seizures, you give 3% hypertonic saline, just enough to stop the symptoms and bring down that intracranial pressure. Step 2. Address the root volume cause. Give normal saline if they're hypovolemic, restrict water for euvolemic SIADH, or give diuretics if they're hypervolemic. Step 3, relentlessly monitor that strict 24-hour correction limit. Conversely, for hypernatremia, our entire approach flips. Step 1, we gotta stabilize their blood pressure first with normal IV saline if they are hypovolemic. Step 2, we mathematically calculate their free water deficit and painstakingly drip pure free water, or D5W, back into their system. Step 3, treat the root cause. Desmopressin for central DI, and, somewhat paradoxically, thiazides for nephrogenic DI to induce a mild hypovolemia that basically tells the kidneys to stop dumping so much water. Wow, okay, we've covered an incredible amount of ground today. But before we wrap up, I want to leave you with this final, really important question. Are we just treating a lab value, or are we treating the patient? And could our cure actually be more dangerous than the disease itself? Because as this explainer proves, mastering clinical medicine isn't just about memorizing pathways. It means deeply respecting the delicate balance of the body and constantly questioning the true impact of our interventions. Every single milliequivalent matters. Keep analyzing, keep asking questions, and use this framework to always see the full picture. Catch you next time.